Good evening, everybody. We'll get started in just 1 minute. Just a reminder to mute yourself as you come in if you aren't already. Good evening, everybody. I'm Kathleen Smith, and welcome to our February professional lecture. And it's an honor for me tonight to introduce Dr. Lance Simkins. I'm going to read a little bit about his bio. This is a topic I know that he presented on at the Florida Fourth International Conference last year, and I missed it. So I'm very excited to get to hear some of his thinking tonight about this topic. And so since 1991, Dr. Simkins has practiced general, interventional, and preventative cardiology, obesity medicine, and clinical lipidology. In 2020, he began providing private Bowen family systems coaching with a research interest in the use of the family diagram in healthy weight management. And Dr. Simkins, in a minute, I'll let you add anything to that bio you'd like to tell us about yourself. Just as a reminder for folks in the audience, please keep yourself muted. I believe Dr. Simkins is going to take discussion at the end of his presentation. So hold your questions until then, and then we ask that you use the raised hand function on Zoom and wait to be called on, and then you'll be free to share your thinking with Dr. Simkins. So I'm going to turn it over to you, Dr. Simkins, and it's your show now.
Okay. Thank you. Let's see if I can get this. Good. Can everybody see this?
Yes.
Okay, great. Didn't want to do that. Okay, what's happening here? I don't know why I'm seeing the admit functions on the screen. Am I supposed to ignore that, or am I supposed to be admitting people?
Just ignore that. We'll take care of it. Because you're a host, you'll see it, but you don't have to worry about it.
Don't know why, but it just wasn't advancing the slides properly, so bear with me. Okay, so this you can all see. I'm trying to start the slideshow from the start. Okay, let's see if it works. Okay, well, hello, everybody. Thank you for your patience with my technical challenges. My name is Lance Simkins, and I first and foremost want to thank Dr. Smith for inviting me to speak. This is what I consider a great honor to speak with you all, especially since I have no background in mental health or your world for many of you. But what I'm going to talk about today is my clinical experience and my thinking in testing the value of systems coaching and weight management and health behaviors. So I've been in practice since 1991 in South Florida, private practice, mostly cardiology, some internal medicine. Got involved about, maybe 10 years ago with obesity medicine. And I'll talk more about that. and then went on to study clinical lipidology, which is a fancy term for cholesterol treatment. And the reason I did it, there was a lot of debate between the obesity medicine world and the cardiology world of what the proper diet is for weight loss and reducing risk of disease. So I've learned a lot, but as I learn more and more, all I get is more and more curious and more questions. So I want to keep learning. I am blessed to have met Dr. Eileen Gottlieb, who has helped me personally and professionally, and has really been the one that got me interested in diving deeper into Bowen theory. And I was invited a number of years back to serve as a board member on the Florida Family Research Network. I am very proud to be part of that. We hosted the 4th International Conference last year, where I did present on this subject. Today will be an update. I apologize if you did see that lecture and there is some redundancy, but hopefully it will be useful. I will put in a plug right away for our upcoming conference, March 8th, which is available live in sunny South Florida. For those of you who are cold, come on down. The weather's fine. We had a great time last year. But it's certainly available online, and early registration is still available through February 18th. And that's our website, FFRN, Florida Family Research Network, ffrnbowentheory.org. There's my free plug. Thank you. Okay, so moving ahead. So testing the value of systems coaching. So what I'd like to do is go over understanding of the physiology of hunger, obesity's impact on health, obesity's related biomechanical, metabolic, and psychosocial effects, the role of inflammation in obesity, psychology and health outcomes, and the uni disease concept. I want to talk about my limited experience with a small number of people since 2019, coaching patients and outside clients with weight struggles using the Family Diagram app, and then a plea for help, because it is not easy to really plan and execute research to contribute meaningful data to science, which is what I'd like to contribute to ultimately. So I thought it would be useful to start with a couple of very evident concepts in Bowen theory. Bridging cutoffs, triangles, conflict, society, emotional process. These are powerful concepts. And most powerfully, I've been, very caught up in a lot of the news over this past month, particularly over the past 2 weeks. And I'm sure most of you are present and watching the news and keeping up with social media. And I don't want this to become too heated of a discussion, but I thought this was an appropriate slide to talk about bridging cutoffs. Everybody recognizes this bridge, the beautiful Golden Gate Bridge in beautiful San Francisco. But it's also the bridge that represents the logo for the Golden State Warriors. And that's really what I really wanted to quickly mention, is that how I've been impacted by the conflict, the social emotional process that's been brought about by social media, all surrounding the drama with Jimmy Butler and the Miami Heat. Jimmy Butler is going through his 4th divorce now, after landing up in Minnesota first and then Philadelphia, coming to Miami. And now, after this divorce, is moving on with his latest affair with the Golden State Warriors. And I thought, if there was a great example in the news, this was probably the one that would generate the least emotion, at least with the crowd. So, thank you for allowing me to throw out my love for my Miami Heat. We will miss Jimmy Butler, but we will embrace the future. And I will invite any and all of you to comment on that later on in the discussion period. Back to business. Okay, overweight and obesity in the United States. This is a graphic that was published in the New England Journal. showing the change in obesity rates across the country over the prior 40 years or so. Realistically, the rates of obesity have been climbing since the 1960s significantly every single decade. And it has been predicted that by 2030, 50% of the country will be frankly obese, and by weight and height. Currently, 70% of this country is overweight or obese. And it is a tremendous problem. To me, we have all just survived this very challenging pandemic. We lost many people. Fortunately, many of us, fortunately, were resilient enough to get through it. But honestly, this is the true pandemic. This is worldwide, and it is causing a tremendous amount of disease and suffering, as well as death, and has just been clear to me throughout my career as an underaddressed and underappreciated topic that needs to be worked on. This will also translate into 1 out of 3 kids developing diabetes. In addition to the known risks of diabetes, high blood pressure, heart attack, strokes, death from any cause, we now know that 13 cancers are higher risk in patients that carry this extra weight. There's probably 15 cancers if you count cancers that are more refractory to the treatments that they need because of the extra weight. So this is something that we have to address. We talk about health behavior change, and we use these terms very commonly: behavior modification, health behavior change. We point out that nearly 50% of the most common cancers can be prevented with lifestyle changes, health behavior changes. And my question that I raise in this arena is that equated to differentiation of self? Sorry, we went 1 slide too fast. So we'll talk about that. In 2012, the American Board of Obesity Medicine was formed and ran their first board certification for obesity medicine. In 2013, obesity was declared a disease by the American Medical Association. Excuse me. That was important because this put it in front of the insurance companies to start covering services, surgeries, medications that would assist with weight management, and has really been a major step of this change. The Surgeon General in 2011 talked about a national prevention strategy. In that publication, he showed that 1 out of every 5 healthcare dollars is spent on caring for people with diagnosed diabetes. People who increase physical activity to 2.5 hours a week, 5 days of 30 minutes, not dramatic, had a 5 to 7% weight loss. And think about that. We're talking about someone who's really struggling with weight at 300 pounds, dropping 15 pounds to 285 pounds. They wouldn't consider themselves probably done losing weight, but I can tell them that they have improved their health dramatically. They reduce their risk of type 2 diabetes mellitus by 58%. A 5% reduction in the prevalence of high blood pressure would save $25 billion in 5 years. And the annual healthcare costs are $1,400 higher for people who have obesity, and $6,600 higher for those who have diabetes. So we want to prevent that diabetes, and obesity is the most common thread. And I will point out here, because I'm going to talk a bit about weight stigma. I'm not sure if this pointer is working, but if it is, it says here, higher for people who are obese. We try not to use that language anymore. We don't consider people to be obese. We talk about people who struggle with the disease of obesity. Just as if somebody who suffers with cancer, we would not call them a cancer person. They talked about in that publication the importance of mental and emotional well-being to overall health. Positive mental health allows people to realize their full potential, cope with the stresses of life, work productively, and make meaningful contributions to their communities. Early childhood experiences have lasting, measurable consequences later in life. This is the need for building a foundation for overall health and well-being. Anxiety, mood, and impulse control disorders are associated with higher probability of these high-risk behaviors. And this leads to the diseases that lead to premature death, cardiovascular events, diabetes, etc. So what can be done? Positive mental and emotional well-being depends on many factors, including quality relationships with family and friends, employment in a positive workplace environment, the ability to participate and contribute to the community, and the ability to access appropriate mental health services when needed. So this was great timing as I was thinking about how to update this talk even more. Last month, the New England Journal of Medicine published this great article on the physiology of hunger, a beautiful overview of our understanding of the science of weight and weight management to date. What they pointed out was three major areas that control hunger: homeostatic hunger, which is basically our genetically derived survival mechanism to ensure that when we are low on calories, we get them for survival. Hedonic hunger is mostly what we will be talking about today, because that is the part that is most linked to the emotional component of this and emotional eating, and honestly is part of what makes it so darn hard. And then finally, the microbiota-driven hunger, which has to do with the microbiome, the trillions of bacteria that live in our intestines every day and live in symbiosis with us, interchanging their chemicals, proteins with ours, and really impacting our health. But it's still kind of a science in evolution in its infancy, in my opinion, that I believe will be very important in the future. So the key points is that hunger is controlled by redundant neuroendocrine circuitries that maintain metabolic balance. Homeostatic hunger, that nature-driven hunger to prevent starvation, is triggered by food deprivation and involves neuroendocrine, endocrine, and metabolic signals that convey the need to eat. Conversely, hedonic hunger, the emotional eating part that we talk about, occurs in the absence of acute caloric need. By increasing the availability of food, agriculture has favored hedonic hunger over homeostatic hunger. The composition and function of those gut microbiota may influence hunger circuitries. However, this exact role is still a little unclear and needs to be worked out better. New knowledge of the physiology of hunger offers new possibilities, new therapeutic targets to modulate food intake in pathologic conditions, including anorexia and obesity. The Power of Food Skill was developed in 2009 to quantify hedonic hunger and assess the psychologic effects of living in food-abundant environments. It uses a Likert scale with many questions to talk about how automatic the behaviors are that cause eating. And again, hedonic hunger happens outside of the true caloric need of the nutrition of eating and hunger, and it favors uncontrolled impulse eating. Some of the sample questions of the 15 questions they came up with, I want you all to think about for a minute. How many of you have these? I think about food even when I'm not hungry. Hearing someone describe a great meal makes me desire food. If I see or smell food I like, I get a strong desire to have some, typically when I'm hungry or not. Before I eat my favorite food, my mouth starts watering. When delicious food is available, I keep thinking about having some. I know I experience some of these things, and I am guessing that quite a few people do. I'll be interested to see the comments later. So the Power of Food scale measures the motivation to consume palatable foods. Both men and women with high Scores direct their visual attention towards palatable food. Functional neuroimaging shows activation of the centers in the visual cortex when they are exposed to images or descriptions of palatable food. People with low scores don't have that same activation, and they don't have the same degree of hunger and craving and food-seeking behavior. Hedonic hunger, as measured by this scale, appears to be related to disordered eating, and limited studies suggest that there's a link between hedonic hunger and an uncontrolled eating impulse, that the degree of hedonic hunger is associated with the magnitude of that eating impulse. Whereas homeostatic hunger is a straightforward survival instinct triggered by only one stimulus, acute calorie deprivation. Hedonic hunger, on the other hand, is multifactorial. It's very complex, involving learning, cognition, and memory. Thus, hedonic hunger is very difficult to tackle on a population basis, but should be approached with the use of an individualized strategy based on the factors at play in any given person. And this is where I see part of the relevance in family systems approaches. In the United States, we spend $800 billion on food. This was in the same article, This Physiology of Hunger, last month. 30% of that food dollar winds up as waste, and that is $240 billion annually. And I'm not even sure how accurately that calculates excess eating by individuals. Nonetheless, according to the International Food Policy Research Institute, it would take $100 billion annually to end world hunger. That's 1/8 of what we spend here in the US. In the US alone, we could save potentially $240 billion and end world hunger if we could make a dent in this and other social problems. It's more complex than just that we want to eat excess food, but it's part of it. Addressing hunger may solve many nutrition-related health problems and make food production more sustainable for the future and equitably distributed to benefit both industrialized and developing countries. So a lot of this work took me down the rabbit hole of reading about emotional intelligence, and I found a lot of relevant passages in Daniel Goleman's book. But one thing I really thought was interesting is how far back this goes. In the book, he references the 16th century humanist, Erasmus of Rotterdam, who wrote about this perennial tension between our executive mind and what I like to think is our caveman mind, or what he called reason and emotion. Jupiter, the Roman god of thunder, lightning, and sky, has bestowed far more passion than reason. You could calculate the ratio as 25-1. He set up two raging tyrants in opposition to reason's solitary power, anger and lust. How far reason can prevail against the combined forces of these two, the common life of man makes quite clear. Reason does the only thing she can and shouts herself hoarse, repeating formulas of virtue, while the other two bid her go hang herself and are increasingly noisy and offensive until at last their ruler is exhausted, gives up, and surrenders. This does sound very familiar when I talk to people who struggle with that challenge of eating food in a way that they can maintain a healthy weight. It's just incredibly hard, the conversations and those arguments that go on inside of the brain. So I actually first presented on this topic to the Obesity Medical Association back in 2021 at their spring summit. And in that talk, I labeled it a hot mess: obesity, inflammation, and cardiovascular disease systems thinking. And I introduced the medical community to systems and systems thinking. In that talk, I brought out, and you should be aware of the medical definition of obesity, and it's a mouthful. The Obesity Medicine Association has defined it as a chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. Whew. Okay, read that carefully. There will be a test where you'll have to recite this later. Good luck. That's a lot, but it really made me sit down and think, what are they really saying here? And what I did was I took this definition and I applied a systems approach towards it. Where thinking about how this increased body fat, the adipose tissue dysfunction, the abnormal fat mass forces leads to the metabolic consequences of dyslipidemia, inflammation, diabetes, the biomechanical consequences, obstructive sleep apnea, the weight on your knees, which makes you stop exercising because you're in pain, the high blood pressure, and then finally the psychosocial consequences, depression, anxiety, and eating disorders. And I really focused in that talk about how all of these things impact heart disease as well as many other diseases. So epidemiologic, cellular, and molecular data support obesity as a condition of chronic subacute inflammation with many markers of inflammation that I'm not going to dive too deep into to muddy up the waters. What I want to show you is in that my world in cardiology, this graphic is showing the layers of an arterial wall in the heart, the coronary artery. And inside, below those three layers, you see a lipid core, which is where that cholesterol plaque builds up, which ultimately pops and causes a heart attack. But what we know now is that is influenced by these inflammatory chemicals that represent inflammation systemically in the bloodstream, but also just outside the heart in fatty tissue that surrounds the heart. And if my pointer is working, you can see it here just above the coronary artery. And it actually creates these inflammatory proteins which leach down directly into the artery, into that plaque, which makes it even more vulnerable to rupture. And we've known about this inflammatory process for a long time in cardiology and how important it is. In cardiology, we have really, in my mind, two types of blockages or plaques in the coronary arteries. There's what we call stable plaque, where people go on to develop plaques in their coronary arteries. But honestly, I've seen and taken pictures of elderly people in their 80s and 90s where these plaques have not caused a symptom or any problem in them, and they have lived in coexistence their entire life with it without any problems. The big difference is an unstable plaque or one that is inflamed. And it is that inflammation within that inner core of that plaque in the coronary artery that makes it pop. And when that happens, there is plaque rupture. And then the body tries to heal that plaque rupture by forming a blood clot on that disrupted tissue. What it doesn't understand is that blood clot is then going to obstruct the entire artery and block the blood flow to the heart, causing the damage that we call a heart attack. Well, some really smart people said, well, listen, if this is inflammation, why don't we really focus on treating the inflammation? And this led to the CANTOS trial, which was published in 2017 in the New England Journal of Medicine, where they look at that. Think about 10,000 patients who had had a heart attack and who had never had any terminal illness like cancer, but they also had elevated levels of C-reactive protein, which is one of the most common markers of inflammation that we measure with routine blood work in medicine. And what we found was people who were treated with this medicine, canakinumab, which was only previously used by our rheumatology friends for their patients with autoimmune disease, this medicine led to a significantly lower rate of recurrent heart attacks than placebo. And that was independent of where their cholesterol levels were or other modifiable risk factors. It was a powerful result. What most of us didn't see coming as a result of that trial was a study that came out after this in the Lancet. And this was just after, where they came out with a secondary finding that the people who were treated with the drug had lower rates of lung cancer after the trial. And Siddhartha Mukherjee, I know I'm going to mess up that name, who is a writer for the New York Times Magazine, a contributor who won the Pulitzer Prize for some of his writing, wrote this article, What We Learn When Two Ruthless Killers, Heart Disease and Cancer Reveal a Common Root. And actually, this first concept was brought to me by Dr. Mike Kerr when he spoke at our winter conference about 6 years ago and introduced me to this concept of the uni-disease phenomenon. And ever since, I have been on board with this, and I have sought out and read more and more information that supports it. The Family Systems Journal that comes out twice a year did a book review several years back that talked about Lisa Feldman Barrett's book, How Emotions Are Made. And it talks about the biology of how we create memories and emotions and the functional way that these are created and recalled instantly, and really explains how automatic behavior happens in us so quickly. What I found really fascinating was the chapter on emotion and illness. And what she points out in her research is, think about the last time you had a cold. You probably had a runny nose, cough, fever, and other diverse symptoms. Most people attribute colds to a single cause, namely a cold virus. And yet, when scientists place cold viruses into the nose of 100 people, only 25 to 40% get sick. So a cold virus by itself can't be the essence of a cold. Something else has to be going on here. The virus is necessary, but not sufficient. And what Mike Kerr went on to talk about was, you need the proper environment, the right physiologic milieu where that virus can latch on and create a pathological condition. Having a problem with your brain, then you see a neurologist. Have a problem with your mind, you see a psychiatrist. In my world, you have a heart problem, you see a cardiologist. You have cancer, you see the oncologist. But now these studies are showing that these are very much related. This modern view integrates the mind and the brain as well as the body, and allows us to understand this differently, but also to think differently about the relationship between mental health and physical well-being and illness. So why do so many disorders share the same symptoms? Why are so many people both anxious and depressed? Is chronic fatigue syndrome a distinct illness, or merely depression in disguise? Are people who suffer from chronic pain with no identifiable tissue damage found on x-rays and examination mentally ill? And why do so many people with heart disease develop depression? If differently named illnesses are related to the same set of core causes, muddying the dividing lines between those illnesses, then such questions cease to be mysteries. And this again supports this concept of a uni-disease process. So again, my work with obesity medicine, just before the talk I gave to that group back in 2021, they had just published what was called the obesity algorithm. And what this was a very extensive collection of the best research and reviews of the research to give an outline of what a proper obesity medicine practice should use as a foundation for their recommendations to their patients and how they treat patients. And they had an entire section dedicated to obesity and psychiatric disease. They gave the top 10 takeaway messages from this very extensive literature. What I focused on during the talk was this number 4. Obesity and psychiatric diseases may share pathogenic pathways involving the immune and endocrine system, hypothalamic and pituitary axis, and the nervous system, and point out the importance of neuroinflammation in this process. Again, to me, consistent with this uni-disease concept. Dr. Kerr also was the first person to expose me to this concept of allostasis and adaptation. And to me, it was a completely new phenomenon, but I have seen it repeated in medicine as well. In the psychology world, we talk about the effects of stress on the brain. Stress is not a bad thing. It creates resilience. It creates us to be creative. It keeps us active. We have to fight or flight, and we have to go out and forage for food, and the exercise helps us. This is evolutionary. Obviously, today is different, and today's mental stress in today's world is literally too much. And it's probably the majority of human beings are under too much stress. And this leads to an allostatic load that can lead to pathophysiologic changes. Allostasis is simply causing change with this adaptation. And that happens normally in the process of storing fatty tissue. What you're seeing here is fat cells. And on the left, you're showing a normal, healthy process of allostasis where we eat and whatever we don't eat gets stored as fat, which as we evolved was obviously necessary to store fat when it was harder to find food in the winter, let's say, or when there was a scarcity, okay, a drought, a famine, whatever. And that excess fat allowed us to survive healthfully, and that was productive. But now that so many people are carrying so much extra weight, the amount of pressure, physical and chemical, is causing this fat to become disordered. And it impairs the angiogenesis or the blood supply to that fatty tissue, reducing the oxygen available to it. It leads to chronic low-grade inflammation, and it causes upregulation of specific factors, in this case, hypoxia-induced factor 1, and increases fibrosis. These have been implicated in cancer biology. So it is these three factors that promote unhealthy adipose tissue expansion, as well as obesity-associated metabolic consequences. Again, allostasis and allostatic load leading to disease. Stress response systems are responsible for releasing glucose into the bloodstream physiologically so that our muscles have the energy to flee or fight predators or other physical threats, or at least in evolution. Today, that's not so much the case. Most of our stress today is psychological. Fight with your spouse, hard times at work, worrying about money issues rather than physical threats. Our bodies nonetheless still respond as they evolve to, as if this stress was physical with hunger. This leaves us in a situation where the excess calories and energy that we eat with that hunger has nowhere to go and tends to ultimately be deposited as body fat. A meta-analysis of many studies showed a clear relationship between stress and weight gain, which probably doesn't surprise anybody. Emotional stress, defined using Andrew Baum's characterization, is a negative emotional experience accompanied by predictable biochemical, physiological, cognitive, and behavioral changes that are directed either towards altering the stressful event or accommodating to its effects. And I do think that is relevant in my world. Both acute and chronic psychosocial stress, as well as early life stress, have been associated with increased inflammatory markers in both laboratory animals and humans. Again, the connection between stress, inflammation, and inflammation as a cause of disease. The inflammation has been demonstrated in the brain. And this is an elegant little schematic that shows the loop that is created when these chemicals are released from fatty tissue and flow through the blood into the brain, where it then leads to or contributes to fear, anxiety, worry, hypervigilance, avoidance, emotional dysregulation. And all of these centers of the brain then feed back to the adrenal glands, which not only pump out adrenaline, but reduce the cortisol levels, which further impact the fatty tissue. This increase in these inflammatory proteins or cytokines may lead to depression. It's certainly associated with it. Depression may enhance the accumulation of body fat further by further emotional eating, further aggravating the process of fatty tissue-induced inflammation. It is a vicious cycle. And when you look across multiple studies of patients that struggle with obesity, you see a clear pattern of anxiety in those patients in multiple trials. The types of obesity are diverse. Panic disorder, social phobia, generalized anxiety, agoraphobia, panic attacks, post-traumatic stress disorder, all demonstrated in these multiple studies. It almost doesn't matter, all different manifestations. And it's complicated. How does stress do this? It's complicated. It interacts with multiple systems in the body. Cognition, physiology, behavior, biochemistry, all of this are contributing to the excess storage of fat, the obesity. The obesity sadly invites more weight stigma in society, and that weight stigma leads to more stress, which leads to more eating behavior, which actually makes it harder to address the obesity and often makes it worse. Weight stigma is a huge discussion in obesity medicine. And this was a review of public health policy looking specifically at ending weight stigma in healthcare, not in the workplace, out in the real world where it's everywhere, in healthcare. The medical field has been amongst the most guilty of practicing weight stigma by simply traditionally telling our patients that struggle to eat less and move more, and really without a clear understanding of how complex and challenging this is. What this article points out is that studies show that weight stigma can negatively impact cortisol levels, the glycosylated hemoglobin, which is the marker for diabetes, oxidative stress, and C-reactive protein, again, that commonly used inflammation marker. Mounting evidence shows associations between weight stigma and increasing food intake, eating in the absence of hunger, emotional eating, binge eating, and long-term weight gain. This really is a vicious cycle, and it's part of it. And it is something that all of us need to be using our best thinking in how we approach this and how we deal with people that struggle with excess weight. The brain centers, again, it's a complex system. The hypothalamus right there in the middle is what really gives us that genetically driven need to eat when our caloric need is there. As we know, that is not the most common reason we eat. So the decision of what to eat and when to eat and how much to eat is quite complex. It's the cortical limbic systems of reward and learning and memory, executive control that are involved with deciding on the quality of the food. The hindbrain is responsible for the size, the amount of the food. But basically, all of this is a complex interplay of systems that are interconnected to make these decisions about what we get in our nutrition and eat. And what this really simply boils down to is choices, decisions, and consequences, which are certainly a concept that some of you are quite familiar with. So how does this integrate? Well, again, without getting too scientific, in the brain centers, there are basically two systems in play. There's the orexigenic system in the pink, showing agouti-related protein, neuropeptide Y, and GABA. In the blue, anorexigenic, which is what promotes satiety and fullness. Orexigenic is hunger, POMC and CARP being the anorexigenic modulators. And what this really represents simply is the gas pedal and the brakes for eating, how your brain physiologically adapts and how it gives input into when to start and when to stop. So the brain is powerful. This I found fascinating that Weight Watchers did a very simple but nice study with the Stop Obesity Alliance and the George Washington University's Redstone Global Center for Prevention and Wellness. And they looked at a large number of patients struggling with weight and talked about food noise. Now, actually, when I read this, I really was not aware of how important this concept is. Food noise is considered constant intrusive thoughts about food that are disruptive to daily life and make healthful behaviors extremely difficult. 2/3 of people wish they didn't think about food as often as they do. They fight the urge to eat even though they aren't hungry. They say that food noise makes it difficult to stick to their nutrition or health plan or exercise plan, and say that food noise makes it difficult to make healthy choices. With constant intrusive thoughts about food, it's difficult to navigate behavioral change without clinical help. The first step is acknowledging that food noise is a real issue that many people are facing. I will tell you here and now that I have food noise, and we can talk more about that later. So, how to turn down the volume on food noise? Well, a number of things help. Managing stress, or as I think of it, reactivity. Optimize sleep quality and quantity, higher fiber and protein intake, and anti-obesity medications. So, the New England Journal of Medicine, again, this premier journal that is probably the most respected. I always respect articles that come out here and are published. It is well reviewed and well respected. Just a little over a year ago, this article was published. Semaglutide, which some of you may recognize more commonly by the name Ozempic, also Wegovy and a number of other knockoffs, these medications that are now being popularized for weight loss, semaglutide in cardiovascular outcomes in obesity without diabetes. Without diabetes. And I want to remind those of you who aren't aware, a reminder to those of you who may be overwhelmed by the weight loss discussions with these medicines, that these were available for years as medications to treat diabetes. And most patients didn't want to take that extra shot and wanted to avoid that if possible, these little injections. Now you can't even get them. There's a back order. So it is a change in mindset. But in this trial, we looked at patients who did not have diabetes, but were struggling with obesity, and looked at their rates of subsequent death, heart attacks, or strokes. And what we found is that it is the synergistic actions of this GLP-1, this pathway that these medications are working on. These are GLP-1 agonists, glucagon-like peptide 1 agonists. They latch on and they stimulate these receptors in the belly and in the brain, acting on both central and peripheral receptors that seem to be responsible for the effects of the hormone on satiety. The study showed a significant reduction in the rates of heart attacks, strokes, and death in patients without diabetes. So this is powerful. Now, it's powerful and is what led to the prescriptions starting to be written for Ozempic initially and many others since. So this is the social media that you see online and everywhere about these medications. And it's confusing. Some of them are pro weight loss drugs. Some of them are against weight loss drugs. Some of them are bragging rights that they lost those pesky extra 5 pounds, which is not the way the drug was intended to be used. Nonetheless, it is out there. And it is important for us as physicians and everybody in this audience who works with people that struggle with weight to understand the impact of social media and be ready to differentiate beliefs versus facts. So beyond hunger, anti-obesity medications have a role. Why? They address biologic and psychological factors that contribute to obesity in a way that other interventions have not. They simply are different type of tools that we've never had before that allow us to address it in a different way. They hit receptors in the gut and brain that affect both satiety, fullness, and the reward centers. They target one or more brain receptors, and doing this quiets food cue reactivity, or what we call food noise. And just to show you, that is only one receptor that we are really working with right now with this popular medication. All of these other receptors are other potential sites that control hunger and fullness, that there is potential for further research and development. And I find it extremely exciting as somebody who practices obesity medicine. And now, again, in talking about this to the group that I lectured to, addressing the psychosocial consequences and how that affects health, and specifically in my world, heart health. So looking at eating behaviors before talking about treatments, dietary restraint is the extent to which individuals attempt to cognitively control their food intake. Disinhibition reflects the loss of control over eating in response to the presence of palatable food or other disinhibiting stimuli, such as emotional distress. Eating without hunger. Vulnerable individuals characterized by disinhibited eating behavior and sensitivity to chronic stress. Will approaching or coaching work on self with Bowen theory as an approach, as is done with chronic anxiety, impact these behaviors? That is the question that I have, and I certainly have thoughts about it. But looking at what's out there, what is the evidence that coaching based on Bowen family systems theory may benefit health behavior change, in particular emotional eating and obesity? Well, again, the Obesity Medicine Association has continuing education, and I attended a course and I reached out to the author, Harold Bays, who has been intimately involved in writing the guidelines for the Obesity Medicine Association, shared this slide with me on the importance and impact of life relationships on body weight. And it talks about relationships in the family, with friends, at work, in the environment, medical encounters, food and physical activity, socioeconomic issues. But right at the top of that circle, as you all see, is self. And to me, it just was a powerful reminder that there is synergy there. And I do believe that work on self is essential for sustainable change in behavior. So my hypothesis has been Bowen family systems theory-based coaching should improve behavior supporting weight loss and maintenance. Behavior change, work on self, guided by Bowen theory, may further man's awareness of how one reacts, understanding one's place as part of a system, allow for more acceptance, avoiding blame and stigma, and enhance one's ability to manage the effort towards sustainable health behaviors, or in my mind, the level of differentiation of self. So the Family System Journal has had several articles that address this. In 2018, an article was published, Losing Weight and Self-Regulation in the Family System by Laura Havstadt and Kathleen Sheffield. And they pointed out in that article that self-regulatory capacity is a limited resource. It is difficult. Variation in situational demands on attentional and cognitive resources affects self-regulation in favor of automatic responsiveness to the environment. That is where that hedonic eating is incorporated. Taxing the attention of dieters with distracting tasks has been shown to increase vulnerability to temptations in the environment at the expense of self-regulatory goals. This is consistent with theory and clinical observation that in daily life, the emotional load, or what we think of as allostatic load, generated by family relationships can run down the attentional and cognitive resources for self-regulation of its members. And again, for me, I think about this and discuss this with my patients as the caveman and the executive, and which one is making the decisions most of the time. Reducing the emotional load of the family emotional system through relationships shifts that reduce anxiety and or enable functioning up for self may be necessary to access the self-regulatory resources for the behavioral changes needed for significant weight loss. And I will add what I believe is most important, maintaining that lost weight, which has always been shown to be the hardest challenge. 80 to 90% of people who lose significant weight gain it back in multiple studies. So it is the maintenance at a healthy weight that to me is the biggest long-term challenge that needs to be addressed. So Bowen theory, Murray Bowen in his book talked about in chapter 12 of Family Therapy and Clinical Practice, how does alcoholism fit into systems concepts? And I'll start here with alcoholism because there's no chapter on eating disorders. From a systems viewpoint, alcoholism is one of the most common human dysfunctions. It exists in the context of an imbalance in functioning in the total family system. Every important family member plays a part in the dysfunction of the dysfunctional member. From a systems therapy viewpoint, the therapy is directed at helping the family to modify its patterns of functioning. The therapy is directed at the family member or members with the most resourcefulness who have the most potential for modifying his or her own functioning. When it is possible to modify the family relationship system, the alcoholic dysfunction is alleviated, even though the dysfunctional member of that family, the one with the quote problem with alcohol, may not have been part of the therapy. And I think anybody who's been practicing Bowen theory based approaches is aware and has experienced this type of thing. My question is, can we simply substitute the word obesity for alcoholism? Will that still apply? Will the next chapter be applied to emotional eating and obesity? And really, this is part of my thesis, my theory, my working theorem. When it's possible to modify the family relationship system, the obesity dysfunction is alleviated, even though the dysfunctional one may not have been part of the therapy. And I do think it makes sense. Time will tell whether we can prove this with meaningful data. Another study looking at the influence of food-related behaviors and emotional performance on the body mass index or weight. The study showed that future interventions should be focused on reducing body mass by modifying the necessary eating behaviors with emphasis on the patient's emotional status and improvements in adaptive skills in order for emotional modulation to be improved efficiently. It is the emotional reactivity that is the most important part of long-term change. And I believe that this is consistent with Bowen theory. Randomized trials of spouse support in weight reduction programs clearly have shown that involving the spouse helps patients struggling with obesity to maintain their lost weight. Preventing critical or unsupportive comments or behaviors by the spouse is as effective as encouraging supportive behaviors. So again, in line with Bowen theory and work on self, simply not trying to overfunction or criticize or help without being asked by a spouse may be just as important as actually encouraging supportive behaviors. Again, when it's possible to modify the family relationship system with any or all family members, the dysfunction is improved or alleviated. 3 factors consistently related to poor health include family stress, inadequate social or family support, family enmeshment. Family enmeshment in this article was dug into even deeper. The difference of family enmeshment or high family cohesion is a specific component of family functioning that is most consistently related to poor health outcomes. So what is this? Family cohesion is the emotional bonding that family members have towards one another. That's typically a good thing. Enmeshment is a pathologically high level of cohesion in which there is a lack of autonomy, where family members overreact to the stress of another family member. To me, this is another beautiful example of allostasis and allostatic load in the family system. When it's possible, again, to modify the system, it is possible that dysfunction will be alleviated. And I just skipped the slide, but I'll do it this way. Another study, family interventions in physical health, how family interaction affects health. So ignore the blue for a minute, but that's what I'm doing, is looking at this through a Bowen lens. Mnuchin and his colleagues at the Philadelphia Child Guidance Center looked at a pattern of family interaction in the families of children with brittle diabetes, severe asthma, and anorexia, which consisted of enmeshment which I think of in Bowen terms may represent fusion, overprotectiveness, overfunctioning, underfunctioning reciprocity, rigidity or conflict, and conflict avoidance, which I think about in Bowen terms as distance. The researchers hypothesized that these patterns of family interaction led to physiological arousal and worsening of psychosomatic illnesses in susceptible children. So hunger. How does hunger work? And is this a meeting of biology and anxiety? Is hunger a true threat? And that the reason I included that is our definition of anxiety is the readiness, a state of readiness to respond to a real or imagined threat. So the question is, if we're truly starving, that hunger is a true threat. But I challenge anyone here in the room, if any of you don't eat for the next 12 hours, are you going to feel hunger? Heck yeah. Are you going to get pretty worked up to find a way to alleviate it? Yes. Well, what would happen if you did not get food and you had access to vitamins and water for the next 24 hours? Would that be a true threat to your health? And for most people, with certain medical conditions aside, the answer is no. It is not a true threat in most of our lives. So this is where biology and anxiety interact. And hunger, I won't say is imagined, but is experienced where the actual threat is imagined. So hunger, is it our earliest, most basic form of anxiety? You tell me. I think most of you recognize that face, a baby crying. Now, there's lots of reasons that baby cry, but the first thing we think of is hunger. And how do we address that hunger? We feed the baby. And look, the baby is smiling. Isn't that a wonderful thing? We do like that. But that is one of the things we think about, or at least I'm thinking about. Is this our earliest lesson in managing stress and anxiety, both as parents and as new human beings? We are fed and we are relieved of that stress. It certainly is interesting. I think Bowen was aware of this phenomenon, as he's quoted as saying, "We all have an infant inside of us, but the infant doesn't have to run the show." I'll leave that to your interpretation. So managing hunger, how does one manage this real or imagined threat? I think we can all agree it ain't easy. The value of a family diagram. So this is a picture of me at 13 at my bar mitzvah with my father, who sadly struggled his whole life with obesity. And again, sadly, it didn't end well for him. He wound up dying suddenly at 62, way too soon. Missed a lot of good stuff. On the top right is a more artistic form of a family diagram that was created by my daughter for her middle school project. And you can't really see it here, but what she points out in the bottom right hand is a quote: "Some family trees bear an enormous crop of nuts." I'm not sure what made her think to include that, but we'll have to ask her about that one day. And down in the bottom is a typical family diagram that we use in clinical work and research. So the family diagram app was introduced to me a number of years ago when I was in the training group in South Florida on Bowen Theory. Developed by Patrick Stinson, and I have found it incredibly valuable for the work I've done on myself and the work I've done with others. And it is, I've done a lot of homework here with a pretty extensive family diagram, and I will let you know this is an old diagram. It's not accurate and not up to date, but it really reflected the work that I was doing on me as part of my family system. Patrick Stinson, I have had communications with. I am amazed by his skills, his intelligence, his insights, but also how hard he works to try to contribute to this cause. And I think he has created a tremendous tool. He has actually collaborated with Laura Hafstadt, who was the author of that article I referenced early about weight in the Family Systems Journal. And together they came up with a concept where they created variables in the application where you can track over time symptoms, anxiety, functioning, relationships, and acute anxiety. And thought this was incredibly powerful and should be an powerful tool for tracking the shifts in emotion over time and how it affects health outcomes and things that can be tracked as factual events. For my interest with weight change and emotional process over time, I learned that I could modify it myself and start tracking weight with clients and look at the weight over time and look at patterns on where it was affected by changes in life situations, life stresses, and major emotional events and shifts. So it has been said that family systems therapy without a family diagram is valuable, but family systems therapy with a family diagram is priceless. And shout out to Jack Butler, who I borrowed that quote from. Studies looking at family dynamics and family-based therapy for pediatric management, putting family into family-based therapy. There's not a lot out there, and that's what I highlight in this article by Joe Skelton. Few studies target family dynamics specifically. A deeper understanding of family dynamics and relationships may provide new avenues to address issues of weight in children, accounting for their family and their underlying functioning. This may benefit the clinician and child engaged in weight management. The US Surgeon General has just recently come out with this guide, really focusing on what he considers one of the most important things of his tenure as Surgeon General, mental health, and created this handout that's available online, his advisory on mental health and well-being of parents, how that affects the parents' health themselves and the children. And it's great that it is becoming in mainstream and supported. One of those same authors, Joey Skelton, was involved with Sebastian Kaplan, looking at family systems theory, and published this article about his experience in using family systems theory, specifically Bowen and obesity treatment. And what he did in that article is really lay out the definitions of the 8 concepts of Bowen theory with triangulation, differentiation of self, the nuclear family emotional system, family projection process, multi-generational transmission process, emotional cutoff, signaling position, and societal emotional process that most of you who are familiar know this, and certainly directly reflects what's available on the Bowen Center website. His review in that article looked back at earlier work from the 1990s, from Epstein's earlier work, which showed that even if only one parent, and most commonly the mother, participated in the intervention, it was still effective. And many other large studies only included one parent as well, despite the fact that it is called family-based treatment. In conclusion, he stated that family-based approaches are the gold standard in pediatric obesity treatment. And although no formal guidelines have been established to direct dietitians and other clinicians in their interactions with family units, our own practice was benefited greatly by applying these principles, the 8 concepts of Bowen theory, as presented. And family systems theory provides us with core principles for approaching behavior change with individual families, and given the known influence of the family system on the weight-related behaviors of children, this theoretical framework has implications for improved outcomes in family-based obesity treatments, which has led me to what I'm trying to do in my practice now, and I am shifting after 35 years of practice, because I see the importance of the emotional health on physical health. And I have created a program incorporating what I am starting with as 18 sessions in the first year of one-to-one direct coaching based on family systems theory, and also using my medical knowledge and skills in obesity medicine and cardiovascular prevention. So again, to review this hypothesis, what I'm really here to do is talk about my experience, share it with you, but also get feedback. what should this look like? How can I publish meaningful data or at least contribute to meaningful data? What are the outcome metrics? What do we measure besides weight? I definitely plan to track inflammatory markers in these patients. But what numbers do I need for meaningful data? I can't do it myself. I know how many patients it takes in a sample size to make something statistically significant and prove that this is a meaningful intervention. So I am looking for collaboration. Which questionnaires do we use? The power of food scale certainly is one. Do we use a scale of level of differentiation? That's been talked about a lot in this community, and it's not well worked out yet how to do that. The optimal use of the family diagram. It is a beautiful tool, but it has a learning curve, and even at its most basic levels is very helpful, but there's a lot more that even I can learn to use it better. The frequency of interactions. How often should you be interacting with a client or a patient to maintain meaningful behavioral change through coaching? And how long did these trials last? In my opinion, this cannot be a one-year trial because the majority of people who lose weight, which has been my experience in doing this so far, do not maintain that lost weight over time. It's going to take years. So this is going to be challenging. So please, if any of you have any ideas, I am open to hearing them. I need feedback, new ideas, collaboration. And once again, a last minute plug about our upcoming conference next month. If any of you are interested, by all means, register. And with that, I will say thank you and hand it back over to Dr. Smith.
Thank you, Dr. Simkins. Yeah, we have about 20 minutes for discussion. So I asked folks to press that raise hand button at the bottom of your screen, and I'll call on you and you'll get to give us your thinking. So I'll give folks a minute to do that.
Sure.
Yes, Randy Frost.
Yes, thank you very much, Dr. Simkins. That was a really comprehensive and thorough uh, look at obesity from so many angles. Um, I, of course, was particularly interested in the family piece. Um, Laura Hofstad, as you know, did this really interesting study of uh, 28 or 30 women who dieted to goal. And in every instance, she and a coworker, co-researcher, could pinpoint a reduction in chronic anxiety for the women who dieted to goal. And I reviewed one of those cases as part of the network seminar, and had to do with a functioning shift of the person out of the position of being responsible for her grandmother, who was a difficult person in a nursing home, and her father took over that functioning position. And those of us who reviewed that all agreed that this would be correlated with a reduction in chronic anxiety. So I imagine she did some version of that with each of the others. But it just raises for me the question of the importance of functioning position in the family. And is it a functioning position that results in the absorption of more than the average amount of anxiety in the system for the person in that functioning position, like the young woman responsible for her grandmother? Um, right now, we're starting some work on trying to develop markers for changes in level of differentiation or differentiated functioning, and see if we can't get some inter-rater reliability uh,
Mm.
on that. And I think it has to do with getting below the question of symptoms or absence of symptoms, and instead looking at the core definitions of differentiation, the integration of thinking and feeling, the capacity to be more of a self, and the like. and looking at a family over time, um, from a baseline of functioning, say at the start of family therapy, and seeing if independent, knowledgeable reviewers can identify shifts in differentiation. So I think,
Good luck with that.
yeah, well, we're going to give it a try. But I think that, that's sort of what you were asking for. Is there a way that differentiation could be, and shifts in differentiated functioning could be identified as part of research?
Yeah, and I think that's the goal, of systems-based coaching, if you will,
Mhm.
is to cause a shift in the entire family system by working on one or more individuals on their own differentiation of self. And for me, it's a bit of a challenge because, as I alluded to in the chapter on alcoholism, it makes perfect sense to most of us that calming down the family or having the family work on their reactivity will reduce the whole family's reactivity to allow that individual with the symptoms of alcoholism to make better choices or get out of their way to make their choices that they know that they want to make. Whether that will happen with my experience probably will be more challenging because the people that come to me are the individuals who are struggling with the symptoms for the most part. And I have not seen a parent of somebody struggling with excess weight who wants to know what they can do, that kind of thing. So it's complex. And yes, Laura's work with that group of women, really one of the highlights that is that it showed that significant shifts in their weight, both up and down, were related to major shifts in both emotional tension and family functioning. So that's from my best recall of that study. And yeah, it's fascinating. Certainly to many of us, it makes sense based on Bowen theory. But just because it makes sense to us is not data, is not science, and definitely want to work towards contributing to that science.
How do we get beyond anecdotal data
Yeah,
to something that's predictable?
yeah.
Yeah.
Thank
Thank you.
All right. Ann McKnight.
Yeah, thank you very much. So I was just curious as to how you think about these weight loss drugs, Wegovy and
you. Yep.
because there are various members of my family and extended family who've used them, and I'm wondering what happens to the anxiety, that's absorbed by this particular symptom. And I just wondered because it's just perplexed me in terms of, that there are couples that have lost enormous amounts of weight, and, is a symptom going to occur in some other area of the family, or I don't know if that's your bailiwick in terms of,
So what you're saying makes sense, and I haven't thought this particular question through before, but what you're saying makes sense for the individuals that are on this tool, and that's how I think about this. I think about this as a tool. These medications are a tool to get you from A to B, just like if you take a medication for anxiety, it is a tool to get from A level of anxiety to B, but does not substitute for the work that it takes for sustainable change. It still takes work. So I see it as a tool. I think there's a lot of excitement about the tool. And certainly from the emotional standpoint, the weight stigma in those individuals is reduced. So that part of the anxiety in their life is reduced. But I don't know that that truly changes their underlying emotional reactivity. It's kind of from a low to a high, but it may still be an extreme. The long-term sustainability is still a question for me. And mostly these medications, just to be clear, are approved not only for weight loss, but they are approved to stay on these medicines to keep the weight off indefinitely right now. And there are personally, I have concerns about what long-term, treatment of any medication is going to be 20 years down the road. Most of the patients that I've spoken to who are on these medications and having success do not plan to stay on them. I ask them that question, do you plan to stay on this for the rest of your life? And most of them say, oh, no. And what I tell them is that, do you have a plan? And it's like, good luck with that, because it ain't going to be easy unless you're working. But that's the beauty. You can bring down that emotional tension with this tool to allow them to do the other work that it takes. And that's where I do think it takes work here. And with the guidance of a properly trained therapist or a coach, I think it potentially may be invaluable.
Well, it just has been perplexing to me. What happens? But
Interesting times, interesting. But I mean, again, I feel blessed as a physician to have these tools. And, I went and got board certified because nobody else was doing this, and I started doing it. Now, every primary care doctor is doing this. So it has taken the burden off of me for being the guy in the area that does this. And I can do the rest of my job, and I can move this other research forward. But it has a lot of doctors are very happy to have this tool, and they're seeing the benefits in their patients, at least short term.
yeah, well, thank you.
Thank you.
Yes, Gail Vorsas, tell me how to pronounce your name. I've got it wrong.
It's my husband, David.
Okay,
Hi, Doc.
David, go for it.
If the process is to treat the family that surrounds the patient, isn't the assumption that we're making that the family is stable and logical and unaffected by their own foibles, so that they're going to be effective at providing this support network? Yeah, I've noticed that the people that I know that have, these sorts of troubles, their family is just as dysfunctional as they are in their own way.
And thank you, David. I think that is the definition and the observation of a family system. And the family system, the way I like to describe this to folks who don't live in this world, is that the level of differentiation that we talk about, differentiation of self, I think of it as a level of emotional reactivity that's like a data plan for a shared cell phone plan. And you get so many gigabytes of data per month, and that cloud of data is constant. But one family member may use more data 1 month than the other. And there are shifts in that amount of usage of the data. And there are shifts in the amount of anxiety symptoms in any family member. But the overall amount of anxiety in that cloud remains constant unless one or more, and it can be any individual, it can be the individual working on their weight or somebody trying to support that person in the best way they can, is the only way to reduce the overall cloud of anxiety that will affect that person. That's the way I explain it and really think about it.
Seems like it'd be nice to be able to find one dysfunctional person in a family surrounded by functional people to do your research on.
That.
But it's an algebra problem, just all variables.
We're all dysfunctional to varying degrees.
Thank you.
Thank you.
All right, anyone else? I thought I saw somebody earlier, but they disappeared.
I guess there's nobody out there that's going to respond to my Miami Heat article. Jimmy Butler? No, I thought I was going to get some Golden State fans to come back at me. No, I guess that it's earlier in California. They didn't get out of work on time.
Well, I have a comment if nobody else does. I was thinking about the use of the family diagram for getting maybe a little bit more neutral about some of these comments you mentioned that family members will make. And I'm thinking about folks I've worked with who, by having that tool, there is over time more neutrality about the reactions and the comments that other people in the system make about their weight or behavioral choices. And it's interesting to see that perspective shift begin to happen. because people are thinking multi-generationally versus how do I get my mom, to stop commenting on what I order at a restaurant or something like that. So, but we got another question, so I'll defer to Thomas Sherman.
Yeah, thank you. And in Dallas, we lost Luca this
Oh, that
week, so
a lot
we
of
feel your
emotion in
pain.
Dallas, and yes, we're still trying to figure out what the heck happened there, but time will tell.
Yeah, we may have to do a family diagram there too.
I hear you.
So I grew up in a family where everyone in my family had a weight problem. And, you talk about that diagram, you could literally draw it out in my family and it'd be very interesting. And then follow through all the gastric bypass surgeries, and now everybody's on Ozempic, and it's one tool after the next to try to fix the problem. So for me personally, what was interesting is I had a life event that ended up changing the way I thought. And that's how I ended up losing almost 100 pounds and keeping my weight off for the last 20 plus years.
Got it.
But what I noticed in the family was that the family dynamics just fed on each other. So one person trying to eat, you really had to have counseling in the entire family because, they'd go to dinner and everybody was eating the bad food or eating too much food. So I'd be curious to see how this model, especially getting into, really family systems therapy, it seems to me like you're going to have the entire family involved in the process if you're going to see and elicit real change. But I don't know if that's possible, but that seems like that's what we would need.
So I think what you're saying, I think I understand what you're saying, and I think I'm going to change what you're saying, and please forgive me, okay? But I agree with what you're saying to some degree. But as I pointed out from Bowen's textbook, and studies that were supported in other people's experiences with children, that it only took the mother to be in family therapy to affect change. And in Bowen's writings, it only takes one individual in a family to change that emotional cloud of anxiety and reactivity to some degree. Now, if you have two people, potentially you can double the improvement in that effect. So yeah, the more people, the better, the more you will have engagement. But I think the people that I've met in this Bowen world, it seems that is the exception rather than the rule for the most part, that the entire family participates. And in my experience and what I've seen and read, even one family member doing their part, even just a little, if you take, and again, if we had a clear, accurate scale of differentiation of self, and you started at a 50 and you got down to a 45, you will help that family system noticeably. It will calm down, even though you're the only one that's working on it. So that is my take for my best understanding, but that's a science that still needs data to understand clearly. Does that make sense to you? Okay, thank you.
All right, since we don't have anybody else, I think this is a good time to wrap up for the evening. Thank you so much, Dr. Simkins, for bringing your thinking and your questions. Hopefully you'll get maybe some emails from folks who want to help you with your research. And thank the rest of you for joining us tonight. I hope I'll see you again exactly a month from tonight for our March lecture with Lauren Arrington from the Family Systems Institute. I'll also highlight our Faith Leadership Conference, which is tomorrow. If you can't get enough of Bowen Theory tonight, come back again tomorrow. And our spring conference coming up at the end of April. And I encourage you to just go to thebowencenter.org and check out those events. So thank you all very much and have a wonderful evening.
Thank you again.